My name is Piotr Sobiestrzyk. I'm an attending physician in the cardiovascular division, vascular medicine section, and cardiac catheterization laboratory at Brigham and Women's Hospital. And I would like to spend the next period of time discussing renovascular and mesenteric artery disease. I have no disclosures to make regarding this presentation. Starting with renovascular disease, let's consider for a moment the fact that while atherosclerosis is quite common and normally the disease that we associate with renovascular disease, there are certainly other causes and etiologies of renal artery stenosis or obstruction. And so fibromuscular dysplasia, vasculitis, specifically Takayasu arteritis, or polyarteritis nodosa can affect renal arteries and its branches. Aortic dissection and stenosis of the suprarenal aorta can diminish flow in the renal arteries and mimic renal artery stenosis. Embolization, be it paradoxical through a patent foramen ovale or from a cardioembolic left-sided source, can certainly cause a hemodynamically significant event in the renal artery. It's important to keep in mind that patients who have transplanted kidneys can develop signs and symptoms of renal artery stenosis because of disease in the iliac artery to which the transplanted kidney is anastomosed. Renal artery dissection can present with signs of renal malperfusion, be it because of trauma, fibromuscular dysplasia, or collagen diseases such as Ehlers-Danlos type 4, for example. Renal artery aneurysms, be it related to trauma, atherosclerosis, or Ehlers-Danlos disease or idiopathic, can cause renal malperfusion via thrombosis. Renal arteriovenous fistulas of iatrogenic nature and renal vein thrombosis can also present with renal malperfusion syndromes. And so when we think about renal vascular occlusive disease, it's important to keep the etiology in mind. Again, atherosclerosis, fibromuscular dysplasia, Takayasu arteritis, small vessel vasculitis, dissection of the aorta or renal artery, thromboembolic disease, be it venous or arterial, and of course iliac artery stenosis of the transplanted kidney. There is, of course, the small vessel disease, nephroangiosclerosis related to chronic hypertension, and of course, also small vessel disease related to diabetic nephropathy. Both of these will lead to decrement in renal function. Starting with some of the less common diseases affecting the renal arteries, fibromuscular dysplasia is often looked for in young patients who present with difficult to control hypertension. Fibromuscular dysplasia is a non-inflammatory, non-atherosclerotic vascular disease which causes luminal narrowing by fibrous, smooth muscle and fibromuscular tissue proliferation, dissection of the media, and potentially aneurysmal dilatation. It's important to keep in mind that the presence of fibromuscular dysplasia in the renal arteries can also mean that the cervical, carotid, and vertebral arteries are affected, and those should be investigated as well. The characteristic appearance of the renal artery affected by fibromuscular dysplasia is described as a string of beads appearance and can be easily seen on the angiogram here. But it can sometimes be subtle, as may be appreciated here, where the abnormality is not easily appreciated, and yet there can be associated stenosis related to these FMD lesions. This is a disease usually of the middle-aged with female predominance, and again, important recognition that the carotid and vertebral arterial beds can also be affected in patients with fibromuscular dysplasia, and of course, vice versa. There are several types of fibromuscular dysplasia. Most of them are best differentiated on pathological examination, but as you can see here, the medial fibroplasia is the most common, and it is the one that is most characteristically manifesting with the classic string of beads presentation on angiogram. Renal artery infarction, as you can see here, can be caused by embolization or dissection, or renal artery aneurysm with component of thrombosis and embolization. Renovascular aneurysms are often incidentally found in patients who undergo CT or MR imaging for other reasons. And they can either be saccular in nature, or more in line with fusiform lesions, which can either represent patients with remodeled dissection, fibromuscular dysplasia, or connective tissue disorders. The causes of renal and, for that matter, mesenteric artery aneurysms can be numerous. When we talk about true aneurysms, which involve all three layers of the arterial wall, atherosclerosis, of course, is common. Abdominal trauma, medial degeneration or medial dysplasia, infection and inflammation, in addition to, of course, hypertension and cocaine and amphetamine use. Connective tissue disorder should always be considered, looking for especially Ehlers-Danlos patients, alpha-1 antitrypsin deficiency, Osler-Weber-Rendu, and patients with fibromuscular dysplasia. Takayasu arteritis usually presents with stenotic lesions, while the distal branches can be affected by polyarteritis nodosa, Wegener's granulomatosis, with the classic appearance of a cluster of grapes at the distal, tertiary, and quaternary branches. Neurofibromatosis and HHT also have been described to cause aneurysms in the renal and mesenteric circulation. The management of renal artery aneurysms is dependent on their size. Natural history of these aneurysms suggests that they are slow to grow, and while feared, usually can be managed conservatively with surveillance until the size of 2 centimeters. When they reach that size, repair, either endovascular or surgical, is considered, though some advocate surveillance even for renal artery aneurysms that exceed 2 centimeters. All of this, of course, is patient-specific, as there's no great prospective or randomized series to guide management of these rare lesions. Interestingly, women are more commonly affected, and usually these lesions are quite asymptomatic, and for one reason or another, it is the right renal artery which is most commonly affected. Vasculitis affecting the renal artery is important to differentiate from the common atherosclerotic disease, as management of this lesion, of course, is quite different. The presence of renal artery stenosis in Takayasu arteritis is more common in patients who come from Asia as opposed to a Caucasian population. The primary therapy, of course, is immunosuppression, steroids, to reduce the inflammation. And it would be ill-advised to treat these lesions with endovascular interventions in the acute phase when the vessel is acutely inflamed. There are, of course, more rare renovascular disorders, such as renal vein thrombosis, which can cause renal failure by obstructing circular arterial inflow into that kidney. And, of course, rarely encountered fistulas, be it iatrogenic or congenital, which can cause a steal phenomenon and result in renal malperfusion, which can mimic with symptoms of an occlusive lesion. That being said, atherosclerosis, of course, is the most common cause of renal artery stenosis. It is common and seen in 5 to 10% of patients with hypertension. It is at the same time the most common cause of secondary hypertension, appreciated in up to 35% of those patients. And it is seen in almost a quarter of patients who have resistant hypertension. Patients with atherosclerotic disease in other arterial beds will, of course, have a higher risk or higher likelihood of having renovascular disease of atherosclerotic nature. After all, it is systemic disease, and therefore it's important to consider renal artery stenosis as a cause of either cardiac syndromes or resistant hypertension in patients who have underlying peripheral artery disease or coronary artery disease. Indeed, if one looks at retrospective and prospective series of patients who have arterial disease, be it arterial aneurysm, peripheral artery disease, coronary artery disease, the prevalence of renal artery stenosis, defined by a stenosis of 50% or greater, is quite high. That does not, of course, mean that every patient with renal artery stenosis has hypertension, which is secondary to that lesion. Very frequently, renal artery stenosis, renal artery atherosclerosis, is an innocent bystander in a patient with essential hypertension. It is, however, clear that in some of these patients, primarily in the era prior to modern medical therapy, renal artery stenosis can be progressive. Progression, worsening of renal artery stenosis can occur in large proportion of these patients, from 30 to 70%. And in some of these patients, the lesion can progress to occlusion. This, of course, dates back to the era prior to modern medical therapy with statins, blood pressure control, and antiplatelet agents. Renal artery stenosis is relatively frequently encountered in patients who have coronary artery disease and who undergo coronary angiography. And so in several studies of patients undergoing coronary angiography who also underwent renal artery angiography at the same time, as many as 20% of them were noted to have greater than 50% stenosis, and in up to 4% of these patients, bilateral renal artery stenosis could be noted. It's also been noted that patients who are discovered to have renal artery stenosis during coronary angiography, patients who do not necessarily have symptoms of renal artery stenosis, those patients have a much worse overall survival compared to patients who do not have renal artery atherosclerosis. And this has been noted over 20 years ago and still holds true. And it likely represents the fact that those patients have a higher atherosclerotic burden. The 4-year survival in patients who have renal artery stenosis is significantly higher than in patients who have renal artery stenosis. And within the group who have renal artery stenosis, the severity of renal stenosis corresponds with decreased survival. So what are the clinical clues that would draw our attention to the presence of renal artery stenosis? Definitely patients who have high atherosclerotic burden, those with peripheral artery disease, and those with coronary artery disease, carotid artery disease, certainly have a higher likelihood of having renal artery stenosis and warrant consideration of renovascular disease if symptoms that can be attributed to it are present. Now, the symptoms and signs, clinical clues to the presence of renal artery stenosis, of course, date back to the famous Goldblatt model of renal artery stenosis, stemming from dog experiments where unilateral or bilateral renal artery clipping was performed to monitor for metabolic and physical clues of renal malperfusion. And so in patients who have unilateral renal artery stenosis, that kidney progressively atrophies with decreased glomerular filtration rate, but renal function can be maintained by hypertrophy of the contralateral kidney. This, of course, can translate into higher renin-aldosterone state, which leads to hypertension in many of these patients. In patients who have renal artery stenosis, atrophy of both kidneys is progressive with emergence of decrease in renal function, azotemia in the presence of angiotensin converting enzyme inhibitors, and difficult to control high blood pressure. The physiology of these two conditions is described here in patients with unilateral renal artery stenosis. A drop in arterial perfusion of the involved kidney leads to increase in the renin-aldosterone levels, which causes hypertension. There's an increase in natriuresis by the normal kidney, which has compensatory hypertrophy. The persistent elevation in renin levels can be treated with ACE inhibitors. And the blood pressure usually can be well controlled with preservation of the glomerular filtration rate for quite some time due to compensatory hypertrophy of the contralateral kidney. In patients who have bilateral renal artery stenosis, the increase in renin-aldosterone state leads to hypertension. There's, however, no compensatory natriuresis and rather volume retention, with poor response to ACE inhibitors, for example, and likely emergence of azotemia in response to these agents, subsequent cortical thinning, loss of renal mass, and consequent decline in glomerular filtration rate. So the clinical syndromes associated with renal artery stenosis are those of renovascular hypertension, usually considered in patients who have resistant, difficult to control hypertension, and who continue to have hypertension despite maximum doses of 3 medications. One of them should be a diuretic. And of course, we have patients who can progress to ischemic nephropathy, decline in glomerular filtration rate, progressive kidney atrophy, particularly those who have bilateral renal artery stenosis. And then, of course, the hypertension and volume retention associated with these syndromes can lead to cardiac destabilization syndromes. And so the classic flash pulmonary edema in the presence of normal left ventricular function, unstable angina, and volume overload syndromes can be a manifestation of renovascular disease. Imaging to identify renal artery stenosis usually involves magnetic resonance angiography, which gives us a very good anatomic definition of the proximal renal arteries, where atherosclerotic disease is most common. It may be less accurate for patients in whom fibromuscular dysplasia is concerned. And in patients who, for one reason or another, cannot be exposed to gadolinium, time of flight imaging without gadolinium can provide us with a good assessment of the renal arteries. Renal artery ultrasound is a safe and inexpensive tool, sometimes limited by body habitus. This technique has been validated in assessment of the stenosis, but it can lack in definition of or defining the anatomical situation. Particularly, it can miss accessory arteries. It is, however, very helpful in assessing the physiological impact of a lesion, and this is done by assessing the renal artery to aorta ratio and comparing the peak systolic velocity in the renal artery as compared to the aorta. And if that ratio exceeds 3.5, that usually is associated with a 60 or greater percent stenosis. And of course, the higher the ratio and the higher the end diastolic velocity in that artery, the higher the suspected stenosis. CT angiography is also a good modality to assess the presence or absence of renal artery stenosis, sometimes limited by the presence of calcification in the aorta or at the renal artery ostia. It is superior to MRA imaging when it comes to looking for fibromuscular dysplasia, as seen in this slide here. Medical therapy for patients with renal artery stenosis focuses on reducing or affecting the atherosclerotic risk factors, which have led to the atherosclerotic lesion. So, of course, smoking cessation, lipid-lowering therapy, and, of course, blood pressure control are the mainstays of therapy. And it's been noted that lipid-lowering therapy can lower the progression rate of renal insufficiency associated with renovascular disease. Antiplatelet therapy has not been specifically studied in patients with renal artery stenosis, which is asymptomatic, but it is commonly used in patients with coronary artery disease and peripheral artery disease, and many of these patients have concomitant atherosclerotic manifestations in these arterial beds. Now, the rationale for intervention and stenting of the renal artery affected by an atherosclerotic lesion stems from the desire to treat the hypertension, which may or may not be related to the renal atherosclerosis. It has been fraught with heated debate over the past 20 plus years, and has been a subject of several imperfect randomized controlled studies. One of the difficulties in deciding who and when should be considered for renal artery stenting is the difficulty assessing the hemodynamic impact of an atherosclerotic lesion. And so, while for a long time it was commonly assumed that a 60% stenosis could be a cause of renovascular hypertension, it's important to recognize that that stenosis does not necessarily correlate with a hemodynamically significant gradient. And this has been a problem with assessing the validity of some of the randomized controlled trials, which have relied on an assessment of stenosis rather than assessment of hemodynamic gradient. So, when should we consider renal artery stenosis? When should we look for it? Well, certainly when we think that we are going to do something about it. And so, in patients who have onset of hypertension before the age of 30, we should look for renal artery stenosis, be it atherosclerotic, be it related to Takayasu arteritis or fibromuscular dysplasia. Same goes for patients who, past the age of 55, all of a sudden develop difficult to control, accelerating or resistant hypertension. Of course, in those patients, atherosclerotic etiology is going to be more common. Patients with resistant hypertension, malignant hypertension should be considered for the possibility of underlying renovascular disease. Patients in whom azotemia occurs after initiation of angiotensin receptor blockers or ACE inhibitors, those are more likely to have bilateral renal artery stenosis. Unexplained renal failure, asymmetry in renal mass can be explained by renal artery stenosis, and of course the cardiac destabilization syndromes mentioned previously should prompt consideration of renal artery stenosis. Those are class 1 recommendations from prior guidelines, which have not been updated in the last 5 to 6 years. Class 2 recommendations traditionally have included patients with unexplained renal failure and those with unexplained heart failure or refractory angina, which could be related to volume expansion or hypertension. Now, once renal artery stenosis is identified, who is going to benefit from potential intervention? And this again brings us back to the fact that definition of a hemodynamically significant stenosis on an MRI or a CT scan or even ultrasound can be of uncertain physiologic importance because the hemodynamic gradient is oftentimes difficult to correlate with the visual assessment of the renal artery stenosis. Traditionally, a stenosis of 50 to 70% assessed visually was considered to be significant, but a more reliable method is of course assessment of the peak translesional gradient with an appropriately sized catheter, which by itself does not cause the stenosis and the gradient, preferably of course with a pressure wire, and that peak-to-peak gradient of 20 or more millimeters of mercury is considered to be hemodynamically significant. As I mentioned, the baseline pressure gradient oftentimes has a poor correlation with a visual assessment of the stenosis on an angiogram. And same goes for the hyperemic pressure gradient and the renal fractional flow reserve assessment. The results of renal artery stenting have always been notable for very good technical outcomes and results, but variable clinical outcomes. And so in this meta-analysis of studies published prior to year 2000, while clinical success was achieved in 98% of these interventions, only about 70% of patients had clinical success, be it improvement or resolution of hypertension or stabilization of renal function, stressing the fact that many of these patients may not have had a hemodynamically significant disease, or they had syndromes which were multifactorial in nature, and in whom renal artery stenosis was just one of the possible etiologies. Smaller series have shown that in carefully selected patients, renal artery stenting can stabilize and improve renal function when there's no other explanation other than renal artery stenosis for the progressive decline in renal function. By far the most common indication for renal artery intervention has always been the treatment of hypertension and the desire to either cure it or improve its control. Some of the classic studies are listed in the left side of the panel. These have all included balloon angioplasty versus medical therapy. We know that balloon angioplasty has been fraught with a high rate of restenosis and has not been successful in maintaining patency of renal artery stenosis. It is stenting, and the studies listed on the right side of the slide, which have been the gold standard of renal artery intervention. The Astral trial, published a decade ago, is often used as a proof that renal artery intervention does not result in improvement in blood pressure control. And it is certainly a trial which has shown that patients with renal artery stenosis of unclear hemodynamic significance certainly do not benefit from renal artery intervention. This study primarily included patients in whom physicians were uncertain if the patient would benefit from the intervention. It was disease of moderate severity and was fraught with high complication rates, which did not reflect contemporary clinical practice. It definitely did show that most of the patients enrolled in this trial had moderate renal artery stenosis, not severe, and most of these patients were not treated with the usual 3 agents or more, nor was the degree of hypertension impressive. In any case, after a follow-up of 60 months, there was no difference in blood pressure control in these 2 arms, patients who were treated with intervention or with medical therapy. And the conclusion was that standard widely spread renal artery intervention for patients with moderate renal artery stenosis who did not have severe hypertension renal artery intervention did not have a role in these patients, and that's certainly true, but one would also say that those patients should not be considered for any intervention other than aggressive pharmacotherapy. It was the CORAL trial, an NIH-funded study, which brought hope that the question of efficacy of renal artery stenting would be answered once and for all. And this large-scale trial aimed to enroll patients with renal artery stenosis of 60% or more, hypertension despite 2 or more medications. So that's not what the guidelines would recommend in terms of considering patients for intervention. And initially, these patients all had to have a proven gradient of 20 millimeters of mercury or more across the stenosis. Because of poor enrollment, that requirement was abandoned, and early on, patients with moderate disease were enrolled without the need to prove its hemodynamic importance. The composite cardiovascular and renal endpoint was the cardiovascular or renal death, myocardial infarction, and hospitalization for cardiovascular events. The study was troubled by difficult enrollment, with most centers having very low enrollment rates. At the time where renal artery interventions were very popular, as you can see in the slide, and so this trial unfortunately represented a small fraction of all patients who were considered for a renal artery intervention. To improve enrollment, the enrollment criteria were relaxed. As you can see here, the blood pressure thresholds were changed, the hemodynamic requirement was changed, and some patients with declining renal function could be enrolled even without the presence of hypertension. Again, the blood pressure in both arms was certainly elevated, but not to a level where we would think of resistant hypertension, especially since these patients were treated with only 2 antihypertensive medications on average. The severity of disease was moderate, of 60 to 70%. Again, the hemodynamic importance of these lesions was not assessed in the majority of these patients. As you can see, after a follow-up of 3 years, the blood pressure control, one of the endpoints, was no different in patients who were treated with an intervention, renal artery stenting, or those who were treated with optimal medical therapy. However, it's important to note that at baseline, these patients had blood pressure which was not treated with the usually required 3 agents to define resistant hypertension, and optimization of medical therapy by adding another agent. As you can see here at the end of the study, the average number of antihypertensive medications went from 2 to 3. That intervention resulted in excellent blood pressure control, questioning the diagnosis of resistant hypertension. One could make an argument that these patients in clinical practice would be treated with a medication rather than an intervention, and these were not patients who by and large would be considered or should be considered for renal artery stenting. The outcomes were no different, and I think the conclusions that should be drawn from this is that in patients with moderate renal artery stenosis, again, average lesion was about 60%, who have moderately elevated blood pressure on 2 medications, certainly are not going to derive any benefit from renal artery stenosis, and we have to be more selective in considering patients for intervention who truly have resistant malignant renal artery hypertension, renovascular hypertension, or critical renal artery stenosis with cardiac or renal syndromes corresponding to it. And so The conclusions from this trial are listed here, and I think the most important take-home message here is that intervention is not appropriate for patients with moderate lesions who have not been treated with maximal medical therapy, and intervention should be reserved for patients who have been treated maximally and who, despite that, continue to have resistant hypertension and indeed severe renal artery stenosis. The most recent guideline update from 2013 supports this and endorses consideration of the diagnosis of renal artery stenosis in patients who develop hypertension at a young age, or who progress to have severe hypertension in their middle age, patients who have malignant hypertension or resistant hypertension. Again, 3 or more agents are required. Azotemia after initiation of ACE inhibitors or angiotensin receptor blockers, and unexplained pulmonary edema. And so the most recent update of the societal guidelines from 2013 supports the consideration of renal artery stenting in patients who have hemodynamically significant renal artery stenosis and unexplained cardiac syndromes such as pulmonary edema or congestive heart failure due to volume expansion related to renovascular disease. A less robust but still present recommendation for consideration of renal artery intervention includes patients who have hemodynamically significant disease and who have resistant or malignant hypertension, again, 3 or more agents, and in those in whom we see progressive renal dysfunction and who have either bilateral renal artery stenosis or renal artery stenosis in a single functioning kidney. Again, patients with hemodynamically significant renal artery stenosis and unstable angina without coronary artery disease could be considered for renal intervention. It's important to note that intervention to asymptomatic renal artery disease in a viable kidney without a cardiac syndrome or significant hypertension is not supported by the current guidelines. Moving forward to mesenteric artery disease, we will briefly discuss mesenteric ischemia, be it acute or chronic, due to atherosclerotic disease, briefly comment on the arterial aneurysms of the mesenteric arteries, which are fortunately rare. The normal mesenteric anatomy is seen in this slide. The celiac artery, seen here in this anterior projection, projects anteriorly from the aorta and bifurcates into the hepatic artery and splenic artery. The superior mesenteric artery, again, originates anteriorly from the aorta and is superimposed here on the aorta, but then moves laterally and supplies perfusion to the small intestine and proximal large intestine, and of course a more distal inferior mesenteric artery supplies the distal gastrointestinal tract. The mesenteric artery aneurysms are seen in about 10% of autopsies, with the splenic artery most commonly affected. They are most commonly asymptomatic and discovered quite incidentally, but increasingly recognized because of the increased use of axial imaging for other causes, and certainly a source of consternation and concern as rupture of these aneurysms is always a feared complication. The celiac artery is very rarely affected by aneurysmal processes. The risk of a rupture, again, depending on size, has been reported in 10 to 20%, though these, of course, are retrospective and inaccurate series. The most common etiology here is atherosclerosis and possibly post-stenotic dilatation or dilation of the artery from compression by the median arcuate ligament of the diaphragm. The splenic artery is the most common artery affected by visceral artery aneurysms. In about half to 3/4 of visceral aneurysms do affect splenic artery. The rupture rates are very low, but can increase in patients who are pregnant because of volume expansion and changes in elasticity of the arterial wall. Endovascular repair of these aneurysms, when they expand or become large, may be difficult because of the inherent tortuosity of this artery, but embolization of the splenic artery can usually be clinically well tolerated because of the rich collateral network, should that be required to manage this aneurysm. Here's an angiogram of a large splenic artery aneurysm. They are most commonly seen in multiparous women. Atherosclerosis is otherwise a common etiology, and the risk of rupture increases with size. Usually an aneurysm over 2 centimeters in diameter can be considered for closure, and unfortunately they often present during pregnancy with rupture, which is associated with high maternal mortality rate. Hepatic artery can be affected as well, with a somewhat higher rupture rate, and this artery is increasingly affected with iatrogenic aneurysmal lesions as a consequence of catheter interventions for chemoembolization of hepatic cancers. Here's a CT angiogram of a hepatic artery aneurysm and an angiogram of a small saccular aneurysm here. These lend themselves to endovascular embolization. Celiac and SMA aneurysms are very uncommon. The superior mesenteric artery is more common in men and usually seen in the proximal segment of the disease. The recommendations for treatment are difficult to categorize because of relatively uncommon occurrence and limited natural history data, but it is usually considered an area where the aneurysms are less predictable in their behavior, and the threshold for repairing SMA branch aneurysms, such as the gastroduodenal artery, for example, the threshold is certainly lower than in other aneurysmal presentations. Mesenteric ischemia can be divided into syndromes of acute mesenteric ischemia and chronic mesenteric ischemia. In patients who have acute occlusion of the mesenteric arteries, arterial embolization is responsible for about 1/4 of these presentations. Atherosclerosis and in situ atherothrombosis represents another 1/4, and in the remaining half of these patients, acute occlusion is iatrogenic or related to vasoconstriction in patients with complex medical disease, use of inotropes. On the other hand, chronic mesenteric ischemia is primarily a disease of atherosclerosis, sometimes vasculitis and radiation injury, and these patients, of course, present quite differently. Acute mesenteric ischemia is a matter of emergency with infarcting bowel, which requires immediate revascularization and resection of the ischemic tissue. You can see in this slide here where the arrow points the superior mesenteric artery with an abrupt cutoff and a thrombus filling the lumen of the artery with some faint trickle of contrast below this lesion. There's no underlying atherosclerosis in this vessel, and this is an acute vessel occlusion. On the other hand, mesenteric ischemia presents in a non-acute fashion with symptoms that are of long duration and are characterized by postprandial abdominal pain with food avoidance and weight loss. And the cause of this disease is primarily atherosclerosis, and usually in order to present with a clinical syndrome, at least 2 of the 3 arteries have to be affected because of the rather rich collateral circulation, allowing normal bowel function in the presence of occlusion of one of these vessels. Here is a CT angiogram of a patient who has occlusion of the superior mesenteric artery with a reconstitution of the vessel via the inferior mesenteric artery and the wandering artery of Drummond, supplying excellent collateral circulation to the SMA and its branches, and preventing the syndrome of weight loss and abdominal pain. Magnetic resonance imaging is a good test to evaluate patients with postprandial abdominal pain. It allows differentiation between atherosclerotic lesions and smooth tubular lesions, which would be characteristic of Takayasu's arteritis. CT imaging is also an accepted modality, which gives good anatomical definition of the severity of the disease and the vessels involved. Mesenteric artery ultrasound is another safe modality which can evaluate the presence of flow in the mesenteric arteries, flow acceleration relative to the aorta, and assessment of the severity of the stenosis. Angiography is reserved for patients who are considered for an intervention. This angiogram shows a tight stenosis of the celiac artery right at its ostium. Treatment of chronic mesenteric ischemia is reserved for patients who present with weight loss and symptoms of postprandial abdominal pain, not in patients who are asymptomatic. These patients traditionally were malnourished and had a high burden of atherosclerotic disease, and their operative mortality rates were quite high when they were considered for surgical bypass. It's therefore not surprising that endovascular interventions have largely become the first-line therapy for patients with chronic mesenteric ischemia, as opposed to those with acute mesenteric ischemia in whom surgery is the first-line approach. The current guideline recommendations suggest that chronic intestinal ischemia should be suspected in patients with abdominal pain and weight loss, especially those with established atherosclerotic disease. And the current guidelines support intervention to treat these patients, preferably with endovascular therapy as the first step. So the take-home points here are worth stressing are that renal artery stenosis is common in patients with systemic atherosclerosis. The classic physiology associated with renovascular disease can lead to resistant hypertension and cardiac destabilization syndrome, as well as a loss of renal function. But in many patients, renal artery stenosis is an innocent bystander in patients with essential hypertension and renal dysfunction triggered by either diabetes or underlying hypertension. And therefore, while screening for renal artery stenosis is worthwhile, intervention should be limited to patients with severe renal artery stenosis and convincing clinical sequela of that disease. Mesenteric artery disease is not uncommon in patients with systemic atherosclerosis. Usually it is asymptomatic due to the rich collateral circulation between the three mesenteric arteries. However, in patients with two or more vessels involved, chronic mesenteric ischemia can become a cause of weight loss and malnutrition, and endovascular therapy should be considered in these patients. Moving on to questions. In this question, screening for renal artery stenosis is most appropriate in which of these patients? A 70-year-old woman with long-standing hypertension who developed hypokalemia when a thiazide diuretic was initiated. A 35-year-old man from Southeast Asia who developed headache in the setting of hypertension, who also has asymmetric arm pressures and who is evaluated during a routine physical exam to be hypertensive. Or C, a 67-year-old man with history of coronary artery disease and carotid artery disease with a normal blood pressure on 3 agents that are not at maximal doses. Or D, a 40-year-old woman with long-standing systemic lupus who also has worsening renal function approaching dialysis. And in this group of patients, it is patient B who likely has Takayasu's arteritis involving the subclavian artery with blood pressure asymmetry and renal artery involvement leading to hypertension, which is malignant. Question 2, the artery of Drummond is A, the third mesenteric artery originating from the aorta inferior to the superior mesenteric artery, the most commonly occluded mesenteric artery in patients with chronic mesenteric ischemia. C, anatomic communication between the inferior and superior mesenteric artery. Or D, an anomalous branch of the celiac trunk seen in 10% of normal population. And of course, the artery of Drummond is a collateral communication between the IMA and the SMA, which arises in the setting of SMA occlusion in patients with chronic mesenteric disease.